Welcome to This Explainer. Look, if you've ever felt like bleeding and clotting disorders are just this chaotic web of pathways, we're going to clear that fog right now. Today, we're stepping into the shoes of an expert coagulation consultant and dissecting hemostasis into an algorithm of absolute undeniable clinical logic. We're getting right into the weeds, granular molecular mechanics and exact diagnostic boundaries. Let's map out the precise molecular forks in the road that literally dictate life or death decisions at the bedside. All right, here's our structured map of choice architecture for today. We're moving rapidly through 5 high-yield modules: primary hemostasis forks, secondary mixing logic, resistance kinetics, transfusion hemodynamics, and finally, we'll wrap up with some incredibly disruptive clinical traps. Let's get into it. Okay, let's set the clinical stage with a massive transfusion scenario. Imagine a trauma patient, right? They're getting massive volumes of packed red blood cells and crystalloids. Suddenly, bam! They start oozing from literally every single IV and arterial catheter site. So what's actually happening here? Well, packed red blood cells don't have platelets, so pumping them in leads directly to dilutional thrombocytopenia and mucosal oozing. We haven't lost the coagulation cascade at all. We've just completely washed out the cellular foundation. This is a primary platelet problem, and it shows up super fast as petechia and mucosal bleeds.
Now let's zoom in and isolate the exact molecular forks of primary hemostasis. When a vessel gets injured, we obviously need a platelet plug, but how does it actually form? It splits into 2 totally distinct vectors. First up, the adhesion vector. This is where glycoprotein IB, or GPIB receptors on the platelet bind a von Willebrand factor on the exposed subendothelium. Then you've got the aggregation vector. This is where platelets actually bind to each other using glycoprotein 2B/3A receptors, with fibrinogen acting as this crucial structural bridge right between them.
So here is the absolutely crucial point. We have to draw a firm diagnostic boundary between a GPIB adhesion failure and a GPIB/IVA aggregation failure. And this gets tricky because the patient is going to present with identical mucosal bleeding either way. On one side of the fork, we have Bernard-Soulier syndrome. That's a deficiency in GPIB, which gives you macrothrombocytopenia, big, giant platelets. On the flip side, we've got Glanzmann thrombasthenia. This is a deficiency in GPIB-IVA. Now, with Glanzmann, the platelet count is actually perfectly normal, but there is an absolute complete failure of the platelets to aggregate and clump together.
Which brings us to a really elegant diagnostic tool, the Hemostasis assay. This is the singular low-frequency variable that definitively splits these 2 primary defects. See, Hemostasis literally forces von Willebrand factor to bind to GPIB. Because of that, if a patient has Bernard-Soulier, their platelets will completely fail to agglutinate on the Hemostasis assay. Conversely, in Glanzmann thrombasthenia, the platelets fail to aggregate with almost all standard agonists, but they uniquely maintain a completely normal response to Hemostasis. Why? Because their GPIB receptors are perfectly intact. It's brilliant.
All right, let's shift gears to secondary hemostasis and see how this logic builds. Say primary hemostasis is fine, but your patient comes in with deep tissue bleeding or hemarthrosis. We immediately look at the coagulation cascade. Specifically, finding an isolated, prolonged APTT forces us to investigate the intrinsic pathway factors 12, 11, 9, and 8. But here's the catch. A prolonged APTT alone doesn't tell us why it's prolonged, does it? We have to ask, is the factory just out of supplies, or is somebody actively burning the factory down?
To answer that, we execute a 1-to-1 mixing study. This is a strictly logical biochemical test that perfectly separates missing parts from active attackers. It's actually pretty simple. We take the patient's plasma and we mix it 50-50 with normal pooled plasma, which of course has a totally healthy, full supply of all the clotting factors. Then we just rerun the APTT and see what happens. The choice architecture here is just so binary and elegant. Check this out. If that normal plasma corrects the APTT, boom, you have a simple congenital deficiency. The normal plasma simply provided the missing ingredient, kind of like handing someone factor 8 in hemophilia A. But if the APTT remains prolonged, if it completely fails to correct, that means you are dealing with a hostile acquired inhibitor, something like an autoantibody against factor 8, or maybe a lupus anticoagulant, and it is actively neutralizing all those fresh, healthy factors you just added.
And here is our clinical mandate. It is absolute. Once a mixing study fails to correct, we must quantify that inhibitor's strength using the Bethesda assay. This is absolutely crucial to guide our bypass agent selection. You can't just blindly throw standard factor replacement at an active inhibitor. It'll just get chewed up. You have to measure its exact kinetic strength so you can effectively bypass it.
Pivoting over to hypercoagulable states now, let's look at factor V Leiden.
It is wild that just a single point mutation here completely destroys the coagulation cascade's natural brake, driving totally unregulated thrombin generation. Normally, activated protein C cleaves and inactivates factor V. But in factor V Leiden, that tiny mutation renders it entirely resistant to this cleavage. And looking at another angle, we have heparin-induced thrombocytopenia, or HIT. This transforms an everyday blood thinner into a massive clot driver through this vicious immunologic reaction that churns out platelet-activating antibodies.
So let's look closely at exactly how we manage these states, specifically when initiating warfarin. We have got to respect bleaching kinetics here. Warfarin blocks the vitamin K-dependent factors, 2, 7, 9, 10, plus protein CNS. But here's the kicker. Protein C has a dramatically shorter half-life than the procoagulant factors. That means the body's natural anticoagulant system completely shuts down before the procoagulant system does. Protein C is the very first to abandon ship, and that leaves the procoagulant factors just running wild for a brief, incredibly dangerous window.
And that exact half-life mismatch leads directly to an infamous clinical trap: warfarin-induced skin necrosis. If you start warfarin in a hypercoagulable patient without bridging them with heparin first, you hit that transient window of zero protein C. That allows massive, runaway microvascular thrombosis to occur, which literally starves the skin of blood flow and causes rapid, severe necrosis. It is a completely avoidable disaster if you understand the kinetics. All right, entering the transfusion hemodynamics module. Picture this. You've got a patient who suddenly develops acute dyspnea, diffuse crackles, and a widened pulse pressure just a short time after getting packed red blood cells. When oxygen saturations tank and airway resistance spikes right in the middle of a transfusion, we have to instantly isolate the underlying mechanism. We are usually choosing between a severe inflammatory cascade or a purely mechanical plumbing issue.
Let's map out the exact mechanical differences here. On one hand, you have TRALI, transfusion-related acute lung injury. This is non-cardiogenic. It's a furious immune-mediated attack right in the pulmonary microvasculature, driven by neutrophils, but crucially, it leaves you with a perfectly normal pulmonary capillary wedge pressure. On the other hand, you have TACO, transfusion-associated circulatory overload, and it is exactly what it sounds like. You have completely flooded a compromised heart. It presents with cardiogenic pulmonary edema, hypertension, and a distinctly elevated wedge pressure.
And here's where the choice architecture forces our hand. Because TACO is purely a hydrostatic volume overload linked to cardiac dysfunction, the immediate clinical divergence relies on aggressively diuresing the patient. Obviously, you halt the transfusion for both. Sure, but the critical path to actually saving a TACO patient is forcing that extra fluid off with a loop diuretic. TRALI, however, is managed with aggressive respiratory support, essentially buying time and allowing that raging inflammatory cascade to naturally subside.
Moving into our final module on clinical traps, we have to confront DIC, disseminated intervascular coagulation. This is where widespread microthrombi formation just aggressively consumes both platelets and clotting factors, skyrocketing your PT, your APTT, and your D-dimer. DIC is triggered by profound systemic insults, right? Things like massive sepsis, severe trauma, obstetric emergencies. The coagulation cascade starts firing so randomly and so aggressively everywhere all at once that it rapidly depletes your fibrinogen and your clotting factors. The result? Simultaneous catastrophic clotting and bleeding.
When we look closely at a blood smear, we can actually see the physical mechanical trauma caused by these microthrombi. They act almost like microscopic tripwires woven across your small blood vessels. As normal red blood cells try to pass through, they are literally sliced in half. Seeing these sheared cells, we call them schistocytes or helmet cells, visually confirms a microangiopathic hemolytic anemia, and that is a huge hallmark of both DIC and our next topic, TTP.
Now, unlike DIC, thrombotic thrombocytopenic purpura, or TTP, is flagged by this classic fat RN pentaid: fever, anemia, thrombocytopenia, renal dysfunction, and neurologic dysfunction. This whole nightmare is driven by a life-threatening deficiency of the 8-MTS13 protease. You could think of the 8-MTS13 protease as a pair of molecular scissors. Its whole job is to chop up these giant von Willebrand factor multimers. But when those scissors are missing, or they're blocked by an antibody, these massive sticky VWF complexes just float through the blood. They grab platelets indiscriminately and create dangerous microthrombi that severely impact the brain and the kidneys. This brings us to our final and maybe most critical boundary. TTP destroys platelets, yes, but it completely spares the coagulation cascade. This leaves the PT and APTT perfectly normal, and that directly mandates emergent plasmapheresis instead of factor replacement. This distinction is absolutely paramount. In DIC, you are replacing consumed factors and platelets. In TTP, giving platelets is literally like adding gasoline to a fire. You must use plasmapheresis immediately to strip out the offending autoantibody and replace that missing ADAMTS13 enzyme.
As we wrap up this explainer, I want to leave you with a real integrative challenge. If a patient presents with mucosal bleeding and uncorrected APTT and rapid onset pulmonary edema, how quickly can you sequence those receptor assays, mixing studies, and volumetrics to actually save them? Because the lines between a simple adhesion failure, an active hostile inhibitor, and catastrophic volume overload, they are drawn in mere molecules and minutes. Mastery of these diagnostic boundaries isn't just medical theory, right? It is the ultimate forcing function in acute clinical medicine. Thanks so much for joining me to trace these pathways today. See you next time.